let's start with pharmacology. Which option best describes the property of competitive antagonism? Okay, so usually a question comes out based on the antagonists and competitive, and they ask the question with Vmax, Km, and they ask how it decreases or increases or no change, something like that. So simple mnemonic: kilometers are increased in a competition. This is the mnemonic I am using. You can use it if you want. So kilometer increasing in a competition. So in a competitive inhibition and a non-competitive inhibition. Okay. In a competitive inhibition, there is increase in Km. Non-competitive, exact opposite. Decrease, instead of Km, put Vmax. Exact opposite. Okay. So here Vmax no change. Here Km no change. Based on this, we can answer. And the right answer for competitive would be an increase in Km. Right. Drug of choice for chemotherapy induced nausea vomiting. Straight question, no confusion. Its answer is ondansetron. Alright. But which is the most potent 5-HT3 inhibitor? It is palanosetron. This is most potent, but still the drug of choice is ondansetron only. Okay, this is the right answer. And in case they ask early chemo-induced nausea and vomiting, like that, still mark ondansetron. But if they ask late chemo-induced nausea and vomiting, you have to mark the pitant drugs, aprepitant, like that. They are the neurokinin 1 antagonists. Okay. And what are the other 5-HT drugs we can remember? Simple drugs. Okay, I mean important ones. 5-HT1A agonists. They are buspirone. Alright, used in anxiety. And then 5-HT3 we have seen, it's used for nausea. And then we can see 5-HT2 inhibitors. One of the important drugs is pizotifen, used in migraine prophylaxis. Okay, and then we can also see 5-HT4 agonists. They are used in constipation patients because they can increase the bowel movement. That is, they are prokinetics. Therefore, they are used in constipation patients. Example drug is prucalopride. These are important drugs. There are many other 5-HT drugs. I just marked out the important ones. This is for anxiety. This is for migraine prophylaxis. This is for prokinetic. So, what is the drug of choice for migraine prophylaxis? It is propranolol. Okay. Optic neuritis as a side effect. Optic neuritis as a side effect. So, these are, what are these? Anti-TB drugs. So, let me write the side effect profile. Isoniazid side effect profile is B6 deficiency, and then it can cross blood-brain barrier and produce hallucinations, memory problems, and it can also lead to neuropathies. What about rifampicin? Primarily, it's an enzyme inducer. That's the major problem we have. Enzyme inducer, what causes drug failure, such as contraceptives. Okay. What about pyrazinamide? Hepatotoxic. And it can also cause joint pains. Ethambutol, optic neuritis. That is the question. So answer would be ethambutol. Next question. Drug of choice in central diabetes insipidus. Okay. Central diabetes insipidus. Drug of choice is desmopressin. That question, one-liner. Okay. So, what are the other options? Tolvaptan is the drug of choice for SAADH. Recently also used in ADPKD, autosomal dominant polycystic kidney disease. Recently approved. What about terlipressin? Terlipressin is the drug of choice for acute variceal bleeding. That is the esophageal varices, those things. Acute variceal bleeding. Desmopressin, in addition to central diabetes insipidus, it is also used in von Willebrand disease and hemophilias. Next question. A former beauty pageant model is currently teaching in a pageant training center and develops diabetes mellitus. Okay, newly diagnosed diabetic. She was extremely concerned about diabetic meds and her possible weight change. So, a newly diagnosed diabetes patient who is concerned about her weight change. So, which drug would you prescribe for its weight neutral properties? So, simple. You just need to find the diabetic drug with the weight neutral properties. Okay, so there are three kinds of drugs. One is weight gain drugs, another is weight reducing drugs, another is weight neutral drugs. Okay, so what are the weight gaining drugs? It is the sulfonylureas and the thiazolinidiones and the insulin. What are the neutrals? DPP4 inhibitors and alpha glucosidase inhibitors. What are the weight reducing drugs? GLP-1 analogs and SGLT2 inhibitors. What are the classes of these drugs? Sulfonylureas are the glimepiride, glyclazide, those drugs. Okay, so this is a weight gaining drug, so this is ruled out. What are the thiazolinidiones? The glitazone drugs. Okay, insulin we know. DPP4 drug. What about GLP-1 analogs? They are the exenatide, liraglutide, those drugs. They are weight reducing, so you cannot use that also. SGLT2 inhibitors are fluoxetines. Okay, so what about the alpha glucosidase inhibitor? It is the acarbose, voglibose, etc. They are weight neutral drugs. The option is not given. What about DP4 inhibitors? They are the gliptins. That is given. It is a weight neutral drug. Therefore, the right answer would be saxagliptin. What about metformin? Metformin is still argued. It could be either weight neutral or weight reducing. That is the property of metformin. So, even though it could also be classified under weight neutral properties, we have a clear drug, clear option is there. Such confusing questions will always come. You should not waste time with such questions and just choose a chance and move forward. Okay. Drug delivered in this device. Okay. This device is called as a freezer. And it delivers insulin, powdered insulin. All right. Note the difference between Afreeza and a salbutamol form, that is a respiratory inhalers. This is a diabetic inhaler. It delivers powdered insulin. All right. Which of the following is the most cardioselective beatable? Direct question, one liner. Answer is nebivolol. Other options: bisoprolol is the second most cardioselective. Okay. And initially there was the first generation of beta blocker which blocked both beta 1 and beta 2, that is the propranolol. Later beta 1 was blocked more and beta 2 was blocked less. This prevented the side effects such as bronchoconstriction. They are the second generations drugs. That's when the cardioselectivity started, and currently the most cardioselective used is nebivolol, and esmolol has a very short T-half. And then there is a drug called carvedilol, which is known for its antioxidant properties, and CCB, that is calcium channel blocking properties also. Okay, and then what else? Okay, that's all. Let's do pathology. A 75-year-old man presents with difficulty in urination, increased urgent frequency. Okay, he also complains of increased urination at night. Okay, he has enlarged prostate, found of rectal examination. Following changes will be seen in the bladder of the patient. Okay, so this points towards the diagnosis of a benign prostatic hyperplasia. So here you should not get distracted and mark hyperplasia, because the question asked is bladder, so not hyperplasia. In bladder, the change is seen as exactly hypertrophy. Because of the benign prostatic hyperplasia, the obstructed urinary flow is present. That is, the urinary flow here is free, but here it is obstructed. So the bladder tries to compensate by putting more pressure by hypertrophying its detrusor muscle and leading to bladder muscle hypertrophy. So the answer is hypertrophy. Neoplasia is cancer, could be benign or malignant. It could be benign or malignant, that is neoplasia. Necrosis is death of tissue. Apoptosis is programmed cell death. 106. A 17-year-old girl has prolonged bleeding after routine dental extraction. Her father and paternal grandmother have experienced similar problems. Okay, so let me quickly draw a family. Father and paternal grandmother. Okay, So who are all affected? This person is affected, this person is affected, this person is affected. So what is the single most likely mode of inheritance? Answer for this is they are continuously affected for many generations. This is an autosomal dominant. If you need the diagnosis, it is most likely to be von Willebrand disease. Okay, that presents like this. Prolonged bleeding after even a normal procedure is mostly von Willebrand disease at this age, and it is also autosomal dominant. Okay, von Willebrand disease. So let me show you some pedigrees. So if skip generations are present, here one generation is skipped, right? Skip generations are present. It is most with and without any sexual sexual, like males are also affected, females are also affected, no sexual preference, then it is autosomal recessive. Skip generations would be present mostly. Okay, here every generation, no generation is affected, no generation is left, so you no skip generations, and female and males are equally affected. So this one is autosomal dominant. Okay, so this one most likely they will not ask you this. Only females are affected and males are not affected. It is most likely to be X-linked dominant. Here actually males are affected, but those babies will not survive. They'll just die because only one X chromosome will be present, and that is also affected in males, means mostly that baby will not survive. So we get an illusion of having only females are affected. This is X-linked dominant, but this is not very important. You may not get this, but this one is very important. Only males are affected. This one is X-linked recessive. Here females are carriers. Here male is affected, and this female is a carrier, and so therefore this male is affected. Here this female is a carrier and this male is affected, but here this male cannot be a carrier, and so here nobody is affected. That is the reason. Okay, female is carrier and male is affected. This is X-linked recessive. What about this one? Female is transmitting disease, but male is not transmitting disease. Female is transmitting disease, male is not transmitting the disease. This is mitochondrial. Okay, so autosomal dominant, all generations, autosomal dominant, all generations will be affected. If there is a skip generation, it is also autosomal recessive. Only males are affected, female are carriers, X-linked recessive. Only female is transmitting mitochondria. Just 4 pedigrees are very important for the exam. This question is pallor, so obviously it is anemia, and irritability and gait problems, neurological symptoms, and then glossitis. Okay, peripheral blood smear is showing this. Okay, this one is a hypersegmented neutrophil. Okay, so this one and along with neurological symptoms and an anemia, it's obviously vitamin B12 deficiency. That's the answer. Why are we ruling out other options? Sickle cell anemia would show a sickle cell in the smear, not this one. And then iron deficiency anemia would show a poikilocytes or pretzel shaped cells, and then also there would be nail changes in the history. There is no neurological symptoms in iron deficiency anemia. And folate deficiency would also lack neurological symptoms, but to be similar to vitamin B12 deficiency, both B12 and vitamin and folic acid deficiency would lead to increase in main corpuscular volume, that is MCV. So how would you, what is the biochemical marker for a vitamin B12 deficiency? It is methyl malonyl CoA, increase in MMA, methyl malonyl CoA. Okay, a 7-year-old child presents with edema and decreased urine output. Okay, edema and decreased urine output. And investigations were done, and serum albumin is 2.5. So serum albumin normally would be around 4, but here it is reduced, so it is just 2.5. It should be around 3.5 to 5.5. Serum creatinine is 0.5 or 3 to 5. Sorry, serum creatinine is 0.5, and creatinine is normal, and urine protein is 3+, which is very, very high. Okay, so there is massive proteinuria, and there is no RBC. Therefore, it is clearly a nephrotic. If there is a blood and the protein is not very high, then it is nephritic. Here it is nephrotic, and the answer here would be minimal change disease. All right, because these two present as nephritic primarily. Nephritic, and this one is nephrotic, but it is an adult disease, not in a child. Therefore, I'm going for MCD. I will just compile a few information. You just have to remember those. That would do. Just take a screenshot or something of this table, and it will be very useful. Just read what I'm marking here. That would do. Okay. So first in PSGN, just read that it is a nephritic syndrome, and there is an immune complex mediated. This one is an immune complex mediated, and there is a subepithelial hump. This is a pathological clincher. They will give you subepithelial hump. Go for post-infectious glomerulonephritis. Simple. Okay. And then RPGN, a very favorite question. RPGN is asked repeatedly. Just read that it is a nephritic syndrome, and it has a linear IgG and C3 deposits. That is very, very important. Okay, just read that it is a linear IgG and C3 deposits. That would do. Nothing else is important. And then membranous nephropathy and minimal change disease. Both are nephrotic syndromes. Okay, and just remember these two. And finally, for membranous nephropathy, it has a subepithelial deposit. That one is important. But in minimal change disease, why they say minimal change is because the light microscopy features are normal, and later when you see an electron microscopy, you can see effacement of food process. That's why this is called as minimal change. These two are important points. Okay, just I'm marking stuff. Read that alone. And then we see FSGS. In FSGS, that is focal segmental glomerulosclerosis. Just know that it is also nephrotic. And then know this one, IgM plus C3 is deposit. That is IgM is important here, not IgG. All right, here it is IgM. FSGS is IgM, so that's why it is important. Okay, and then in MPGN there are two types. One is type 1, another is type 2. Type 2 is also known as dense deposit diseases. They give this word dense deposit. Okay, and then they expect you to write how they ask this dense deposit is. They give only C3 deposit is shown. In this case only we see only C3 without any antibody. Therefore, this one is unique, and they will ask this one. They may give MPGN type 2, or they may give dense deposit. So read this one. And then also no, and this one is easy. Direct name is there. And then here there is subendothelial deposit. Do not get confused. Membranous nephropathy is subepithelial, and MPGN type 1 is subendothelial. Okay. And then in MPGN, immune complex mediated. Type 1 is immune complex mediated. Next, IgA nephropathy is mediated by IgA. Important one is the hematuria and proteinuria are very, very recurrent. All right. And then there is focal mesangial proliferative glomerulonephritis. That one you have to remember. And finally, there are dense deposits seen in mesangium and paramesangium. Okay. These are the important points. Just whatever things I have marked, just read that alone. Take a screenshot of this slide. I'll give you a second. You can take a screenshot. Okay, just mark these things. Just before going to exam, just see these stuff. That would do. Okay, this is very important. C and K antibodies are characteristic feature of. Okay, before we go into this, we will see what is C and K, what is P and K. C means cytoplasmic. P means perinuclear. It is around the nucleus. I will show you an image. See here, you can note that P and K, no, it is seen around the nucleus, right? So here you can see the pattern, but here it is seen in the cytoplasm. That's the pattern here. That's the C and K. Okay, in this image we can see the C and K. It is cytoplasmic. Here it is only perinuclear. Okay, so here remember these two. This is important. What is medium vessel? What is large vessel? Okay, large vessel is Takayasu giant cell. Medium vessel is polyarteritis and Kawasaki. In ANCA associated this one, in ANCA associated small vessel vasculitis, what we have to know is that granulomatosis with polyangiitis is nothing but vaginers, and eosinophilic granulomatosis with polyangiitis is nothing but Churg-Strauss syndromes. They're just other names. Okay, just remember Churg-Strauss has been associated with eosinophilic granulomatosis. That's the same disease with different names. And these three are associated with ANCA. So which is which? Okay, so we have three disorders. That is vaginers, Churg-Strauss, and one more is microscopic polyangiitis. I would like to just say there are C and P, right? So C is the third letter. So 3, if we turn, it may look like W, no? So therefore, you can remember C is Wegeners. That is C and K. Therefore, in this question, the right answer would be Wegeners. Both these three, that is Church straws and microscopic polyangiitis, both of these two belong to P and K. Okay, Wegeners is C and K. Next question. A 45-year-old presenting with painless supraclavicular lymphadenopathy. Okay, painless. All right. Biopsy was taken. Presence of binucleated owli appearance. Binucleated owli appearance with clear vacuolated space. That is a vacuolated space. Cell was CD15 and 30. Okay, easy clinching. The answer is Hodgkin's lymphoma. What are the relevant points? It is CD15 positive, 30 positive, and it has Reed-Sternberg cells. This Reed-Sternberg cell is given notated by this definition. Okay, so all this points towards Hodgkin's lymphoma. Okay, show you the difference between Hodgkin's lymphoma and non-Hodgkin's. Both have B symptoms: fever, night sweats, weight loss. That is the B symptoms. Remember this. They may ask which is not a B symptom like that. Remember this one very well. And Hodgkin is somewhat better prognosis than non-Hodgkin's because it involves a small group of nodes rather than a multiple lymph nodes in case of non-Hodgkin's, and it has a bimodal distribution, but non-Hodgkin's can affect everyone. Okay, this is enough here. And in Hodgkin's lymphoma, there are few types. Just remember that lymphocyte rich is best prognosis, whereas lymphocyte depleted is seen in immunocompromised patients. Nodular sclerosis is the most common type, and even Reed-Sternberg cells is classically seen in a nodular sclerosis type. And they have given a mnemonic. I think it's easier without a mnemonic given. 1530 and Reed-Sternberg cell. All this points towards Hodgkin's lymphoma. Okay, a 2-year-old boy presents with a history of recurrent infections, soft tissue abscess in paravertebral area, and multiple liver abscesses, hepatosplenomegaly. Okay, he's having multiple infections, and they have given a clue also. It is due to a NADPH oxidase complex of phagocytes. That is a defective. So the disease here is called a CGD. CGD, which is chronic granulomatous disease. Okay, so this is CGD. So the test done here is nitroglycerin test. The uniqueness in this test is it tests the reactive oxygen species generated by the phagocytes. Okay, so if the phagocyte is normal and they generate a ROS, the nitroglycerin will be positive. So therefore it is positive in a normal patient, but in an affected patient it is negative. Okay, since here there is defective, the answer would be negative. Okay, so nitroglycerin test, which is also known as the a nitroglycerin test, is positive in normal people, negative in affected people. Okay, that is the tested point here.
Let's continue with microbiology. And the first question is, a 20-year-old man presents with 2-week history of mild cough, weight loss, low-grade fever, and night sweats. He spends his weekends exploring caves. Culture smear shows the following. What is the most likely diagnosis? And smear shows tuberculate macroconidia. So option is answer A, TB. Let's move to the next question. A high level disinfectant can kill bacteria, fungi, and even the spores. Which of the following is a high level disinfectant? And it's a straightforward question, and option A is the right answer, chloraldehyde, whereas alcohol and phenol are intermediate disinfectants. Coming to the next question. A 17-year-old student returns from a backpacking trip to Nepal with a 2-week history of offensive diarrhea and weight loss. A smear of intestinal biopsy revealed many trophozoites. What is the best treatment option? Coming to the diagnosis, a 2-week history of offensive diarrhea and weight loss, intestinal biopsy revealed many trophozoites, indicates giardiasis. And drug of choice for giardiasis is C. metronidazole. Ciprofloxacin is given in infectious diarrhea and gluten-free diet in celiac disease. and prednisolone in inflammatory bowel disease. So, coming to the next question, a 77-year-old male with a history of fever was diagnosed with COVID-19 infection. He has a history of hypertension and diabetes mellitus for past 20 years and takes medication regularly. A few weeks after hospital discharge, the patient developed a nasal congestion, facial pain, and blackish nasal discharge. KOH mount reveals non-septate hyphae at right angles. What is the diagnosis? A KOH mount reveals a non-septate hyphae at right angle indicates a mucormycosis, and next possible answer might be aspergillosis. But in aspergillosis, there is a thin septate hyphae at acute angle, whereas in mucormycosis, it's a non-septate at right angle. And coming to the history, the patient develops nasal congestion, facial pain, and blackish nasal discharge indicates fungal infection. And with the recent scenario with COVID-19 infection and increased opportunistic infection of mucormycosis also indicates option B, mucormycosis. So answer is mucormycosis. Let's move on to the next question. A 50-year-old female came into the hospital with a history of fever, headache, and vomiting. CSF analysis showed the presence of gram-negative diplococci. Identify the organism. From the given four options, Streptococcus staphylococcus or gram-positive cocci. So it can be ruled out. Whereas Neisseria meningitidis and Neisseria gonorrhoeae are gram-negative cocci. With the history of fever, headache, and vomiting, we can find it is a meningitis. So option C, Neisseria meningitidis, is the right answer. Moving on to the next question, identify the organism. In this given smear, we can see a rod-shaped bacilli with a polar body, which is nothing but metachromatin, which is a metachromatin granules. So option C, Corynebacterium diphtheria, is the right answer. And the given stain is the Albert stain, which is a differential and confirmatory stain for Corynebacterium diphtheria. And Corynebacterium diphtheria can be cultured with Loeffler's agar and Tinsdale tellurate agar. The next question is, owl eye inclusion bodies are seen in. From this given smear, we can see a owl eye inclusion bodies, which is intranuclear inclusion bodies, a basophilic inclusion body, and option A, CMV, is the right answer. And some other inclusion bodies seen in viruses are rabies, negri bodies, molluscum contagiosum, Henderson-Patterson bodies. And these both inclusion bodies are intracytoplasmic inclusion bodies, and in measles both intracytoplasmic and intranuclear inclusion bodies are seen, and the inclusion bodies in measles are called as Warthin-Finkeldy giant cells.
Let's do forensic medicine and toxicology. Criminal responsibility of an insane person is dealt under which IPC? Okay, so criminal responsibility of an insane person is dealt under IPC 84. This is a direct question, and there was a previous rule called McNaughton's rule, but currently we are maintaining it under IPC 84 for insane person. What about the other IPCs? 82, 83. 83 deals with the criminal responsibility of children under 7 years, and 83 deals with the 7 to 12 years. They are completely not, they're not responsible. This is based on mental maturity. 84 we have seen. What about 85? 85 and 86 deals with drunk that are intoxicated by any substance. but in 85 it deals with involuntary, that is they did not take the substance voluntarily. Here 86 deals with voluntary intake. So these people are responsible, these people are not responsible. These are the IPCs. An 56-year-old man was brought into the emergency by his wife because of memory loss and difficulty in walking. Noticed personality changes. Uncooperative, smells of urine. He is diaphoretic and tremulous. Gait is wide-based. His oculars are normal, but there is nystagmus on lateral gaze. Multiple admissions for alcohol. Okay, this is a case of alcohol withdrawal. What is the next step? The next step is diazepam. So in alcohol withdrawal, what happens? First, in the 6 to 12 hours, the patient will be starting to get withdrawal. The symptoms will start, and then it will start with the tachycardia and sweating like that, diaphoresis like that, and then at 36 hours it peaks. At 48 to 72 hours, the tremors start. That is the delirium tremens start, along with coarse tremors, and then confusion, and then delusion, and then auditory hallucination, visual hallucination, and then a fever, tachycardia. Everything happens at 40 to 72 hours. At this time, we treat them with long-acting benzodiazepines such as diazepam. Okay. Now, was working in his farm and he was bitten by a snake, which was later found to be a cobra. Okay, what the venom? Which venom is cobra venom? So the cobra venom is a neurotoxic venom. Okay, cobra, great, or neurotoxic. Sea snakes or musculotoxic. Vipers or vasculotoxic. All right. Next question. What is this wound? This is very simple, abrasion. Why? Because in a laceration, I'll show you some images. This is an incision, clear cut. You can see the tissue inside. Here, even the tissues are broken. Okay, this is a laceration. This is done with a blunt instrument. This is done with a sharp instrument. Okay, you can see further images of lacerations and incisions. So our image is an abrasion. Okay. What is this spinal poison? So this one is strychnine. I'll show you the images of others. This is a strychnine, please remember, strychnine. This is a cannabis, option D. So cannabis looks like this. This is atropine toxin. Okay, this is atropa belladonna. This is atropa. This is datura. Note the flower. And there also the fruits and the seeds. Okay, the flower is important to read. Atropa, you see this black color, and cannabis you can identify easily.